So this is our seventh Global Breast Cancer Seminar. The goal of this seminar is to provide educational opportunities for free for those physicians and providers who are taking care of women with breast cancer in low and middle income countries. Today we're moving on to discuss difficult topics, and that is specific breast cancer subtypes. And we have two outstanding speakers that I know well that will guide us through these difficult topics. Again, as usual, we'll have back-to-back presentations, and at the end, I will take your questions. And so during the presentations, if you have questions, please write them down in the chat. There'll also be time at the end to raise your hand virtually. So our first presentation is going to be by Dr. Dami Idossa. I've known Dr. Idossa for a number of years. She is a medical oncologist at the Mayo Clinic. She used to be at the University of Minnesota, where I work. She specializes in the treatment of breast cancer. She's particularly interested in triple-negative breast cancer, in postpartum breast cancer, survivorship, and clinical trials. In addition to her clinical activities, her research has been focused on cancer care delivery, symptom management, quality of life, and improving access for patients to clinical trials. Her work has been published in many prestigious medical journals, and she's the principal investigator for numerous studies and serves on national committees for symptom management and improving clinical trial accessibility. So please welcome Dr. Idossa, and Dami, we're looking forward to your presentation.
Thank you so much. Give me 1 second. I'm having a hard time with my computer, so I'm changing. Okay, can you guys hear me okay?
Yes. And we see your slides.
Okay, perfect. Good morning, everybody. Thank you so much for having me this morning. My name is Dami Idossa. I will be spending the next 20 or so minutes discussing about triple-negative breast cancer, both in the early stage setting as well as the metastatic setting. So just general concepts, triple-negative breast cancer is or can be a very aggressive subtype of breast cancer. In the US, at least, it makes up about 10 to 20% of all breast cancers across the globe in different parts of the world. Obviously, that number can be a little bit higher. It can have a pretty heterogeneous histology. Some can be indolent, like adenocystic carcinoma, but others can be much more aggressive, like metaplastic carcinomas. But the majority of them, sort of the classical triple-negative breast cancer, does tend to be more aggressive. And then from a biology standpoint, tends to be pretty proliferative. And so what that means is it's going to be much more chemo responsive, but unfortunately there's also rapid development for resistance to treatment. And unfortunately, many recurrences that happen after patients have received appropriate therapy. So because it is pretty responsive to chemotherapy, when folks get systemic therapy before they go to surgery, so in the neoadjuvant setting, there are pretty high rates of complete pathologic response. But unfortunately, again, as I mentioned, there can be frequent recurrences. Most tend to be within a year or so after completing treatment. And if that happens, the median survival after they've developed metastatic disease can be fairly short. And so this is the general treatment strategy that I think about when approaching early stage triple negative breast cancer, so stage 1, 2, or 3. We won't spend too much time talking about management of stage 1 triple negative breast cancer today, but I will focus most of my efforts on management of stage 2 and 3 in the early stage setting. And then you can, of course, refer back to this for how I typically think about managing stage 1. So this was one of the landmark studies that were done about 5 or so years ago now, since its presentation, where they took patients with stage 2 or stage 3 breast cancer, randomized them to getting chemotherapy. So the backbone here was carboplatin paclitaxel with an anthracycline. You could use either doxorubicin or epirubicin with cyclophosphamide. And these patients either got it with placebo or with immunotherapy, and they went to surgery. And the primary outcome here was complete pathologic response at the time of surgery. Patients after surgery, so in the adjuvant setting, did continue on to get pembrolizumab every 3 weeks to complete a year of treatment, or they received placebo to complete a year of treatment. Here's the patient characteristics, and the main thing I want to highlight here is that many of the patients that were included in this trial were really folks that presented with smaller tumors. So T1 or T2 disease really made up about 74 or so % of the patient population. About half of these patients were presenting with node positive disease. Of course, in other parts of the world, patients can be presenting with much more larger tumors and more nodal involvement at the time of presentation. Here is the primary outcome for that study, which is really looking at the pathologic complete response rates. And you can see here on this bar graph that adding pembrolizumab to chemotherapy does improve the complete pathologic response rates compared to chemo alone. And that absolute difference was about 13.6%. And then to the figure to the right here, we're seeing that the event-free survival is a little bit higher in those who received pembrolizumab with chemotherapy compared to chemotherapy alone. And then looking a little bit more at what chemotherapy does in terms of even for those who had residual disease. And what this bar graph is showing is the proportion of patients in each arm who had residual cancer burden of 0. So that essentially means complete pathologic response. RCB1 is sort of moderate or small amount of disease. RCB2 is moderate amount of disease. And RCB3 is a lot of disease, essentially, is how I think about it. And you can see for each of these subgroups, the immunotherapy does lower the number of patients who are achieving or are in each of these classifications, suggesting that it's pushing more and more folks to a lower RCB category. And RCB is really important because it is correlated with event-free survival. On the figure to the left here, you see that those who achieve an RCB 0 or a complete pathologic response actually do better. So that's shown in the top line here in black. And with each increasing RCB, you can see that the event-free survival worsens. And unfortunately, with RCB3, you see we have quite a lot to do here to improve outcomes for those folks. So adding immunotherapy here, we can see does seem to sort of shift folks to a lower RCB criteria or category. And then breaking that up a little bit more, you see if we're just looking at those who achieved a complete pathologic response on that trial, adding immunotherapy does have a benefit, but it's a really small benefit. You can see the difference between these two lines is really challenging to see, but technically a small difference that's still seen even among patients who achieve a complete pathologic response. There's a lot of debate now as to whether that benefit is from getting the immunotherapy in the neoadjuvant setting, so before patients go to surgery, or whether there's that benefit of continuing the immunotherapy, so after patients have had surgery. There's currently trials that are looking at trying to address this question by randomizing patients to continuing on to immunotherapy versus just stopping if they've achieved a complete pathologic response. So hopefully soon we'll be able to answer that question. And then looking at folks who have achieved an RCB1 disease, so a little bit of disease left at the time of surgery, it's really hard to say whether immunotherapy makes a lot of difference here, but the numbers, if you look to the right, are fairly small here. So it's a smaller subgroup to really be able to address. But right now in the US, the standard therapy is to continue immunotherapy to complete a year of treatment for these folks. The bigger difference really comes up in the RCB2 category. And you can see here, there's a clear difference between the two arms. There's with the chemo plus pembro arm, you can see that the events are about 25%, so recurrence, event-free survival is what we're looking at here. And then with chemotherapy, that's about 56% or so. So for this group of folks, we certainly do continue immunotherapy to complete a year of treatment. And then I'll also be talking a little bit about what else we might be able to do for these folks who have residual disease. For the RCB3 category, again, these are small numbers, but what we're seeing is really that immunotherapy doesn't seem to make a whole lot of difference here. I think we have to be careful about the interpretation just given the small numbers, but I think the bigger picture here is that we're seeing the folks who have very resistant disease and do not respond to all that they've received in the neoadjuvant setting really do poorly, regardless of what treatment they get. And so this is really a subgroup where we have a lot of work to do to try to improve outcomes. So summarizing this data a little bit, so overall for all comers, we're seeing the event-free survival is improved by about almost 8% with adding pembrolizumab to chemotherapy for patients with stage 2 or 3 breast cancers. Excuse me. And then the distant relapse-free survival is also improved by about 6% with adding immunotherapy compared to chemo alone. This benefit was seen independent of PD-L1 status, unlike in the metastatic setting, which I'll review soon. So we do not test patients for PD-L1 status in the early stage setting. And then there was a greater benefit, as I just showed, in those patients who did not achieve a complete pathologic response with neoadjuvant chemo and immunotherapy. Now we have to also consider the potential toxicities of adding immunotherapy to chemotherapy. And in this figure here, you are seeing that we are causing more side effects by doing so. So it does come at a cost. And primarily these side effects seem to be immune-mediated side effects. So as you rev up the immune system, it's good from a cancer standpoint because the immune cell is able to effectively also go after the cancer cells. But unfortunately, sometimes there can be kind of unintended consequences of the immune system being overactivated against your own cells. So that's what we see here on this figure, that we're seeing much more infusion reactions, hypothyroidism, and all of these things that are listed here that are grouped as immune-related side effects. So importantly, even the higher grade toxicities, so grade 3 to 5 reactions, seem to occur at pretty decent frequencies. About 15% of the patients treated on this trial unfortunately had immune-related side effects. Now that we've been using immunotherapy much more frequently, we are much more attuned to what these side effects are and are able to screen for things like hypothyroidism and adrenal insufficiency. And then for other things like pneumonitis or hypophysitis or colitis, we're able to recognize them a little bit more quickly and conduct the appropriate studies to evaluate for those things so we can manage appropriately. So all of that is great data, but how do we really apply this strategy to lower middle income countries where immunotherapy might not quite be as readily available, or if it is, it might be really cost prohibitive for many patients. So this is really interesting study that came out of India, was presented at ESMO just about 2 weeks ago, where they took a very similar patient population of folks that had stage 2 or 3 breast cancers So very similar population to the Keynote 522 study. They randomized them to getting AC for 4 cycles, as well as dose-dense Taxol for 4 cycles. These patients did not receive a carboplatin as we do in Keynote 522. Half of these patients were then given 3 cycles of pembrolizumab, but only at 50 milligrams given every 6 weeks. The standard dose here would be 400 milligrams given at every 6 weeks, so substantially less than what we would give for standard therapy. The primary outcome they were looking at was really what the complete pathologic response rate was. And here I just really want to highlight the patient characteristics, primarily that they are patients who most of them are presenting with much higher disease. So T3, T4s, the majority, 83%, had nodal involvement at the time of presentation. Most of these folks were presented at stage 3 disease, so probably more comparable to patients that are seen in different parts of the world. And here's their primary outcome showing that they're able to improve the complete pathologic response rate by about 13% by adding low-dose immunotherapy to standard chemotherapy. And this absolute benefit is pretty similar to what we saw in the Keynote 522, which was also about 14% absolute benefit by adding full dose or standard dose immunotherapy to chemotherapy. And so the point I want to make about this trial is that, they didn't really compare it to what outcomes would be with standard dose immunotherapy, but I think really just highlights the importance of thinking creatively and figuring out how we can allow more patients to be able to access clearly very effective treatment strategies in different parts of the world. So I think it's certainly hypothesis generating and can potentially be standard therapy in different parts of the world because of the design where it didn't have a standard comparator arm of including a full dose immunotherapy. We can't really say that it is practice changing, at least here in the US. And then moving on to really this cohort. So we have treated patients with neoadjuvant chemotherapy. Then we're really assessing what the response was to that neoadjuvant systemic therapy. People can fit into 2 boxes. Either they've had a complete pathologic response or they have residual disease. And if they have residual disease, then we really care about what their germline genetic status is, primarily whether they carry a germline BRCA1 or 2 mutation, because the types of treatments that we would recommend are different depending on whether they would have residual disease and what their germline genetic status is. For patients who've achieved a complete pathologic response, as I mentioned earlier, currently the option is, and the standard is to continue immunotherapy to complete a year of treatment. But you can see from that figure I showed earlier that that difference is really tiny. Folks who achieve a complete pathologic response do really well. And so there is a trial to really consider stopping that in the adjuvant setting. And so hopefully we'll have that data soon. But I'm going to focus some time on really the residual disease group and what we do about those folks. So the CREATE-X trial was a trial that was done several years ago now that took patients who received some neoadjuvant systemic therapy for HER2 negative breast cancer. So this also included patients who had ER/PR positive breast cancer, HER2 negative. And they randomized them to getting standard therapy for about 6 months, about 8 cycles of capecitabine given on a 2-week on, 1-week off schedule. And what they found from this trial is that we are able to improve the disease-free survival. So you can see on the figure here that the absolute benefit is about 14% in improving disease-free survival. We also see an improvement in overall survival, which is important, so about 8%. And primarily this benefit seemed to be driven by the folks who had triple negative breast cancer as opposed to ER/PR positive, HER2 negative. And so prior to having the Keynote 522 data, this was the standard treatment for patients who had residual disease after neoadjuvant therapy. Now that we have the Keynote data, many of us are really combining the two. So giving both immunotherapy and capecitabine at the same time, or sequentially in some cases, for patients who have residual disease after neoadjuvant chemotherapy, but do not have a BRCA1 or 2 mutation. And then moving on to the folks that have a BRCA1 or 2 mutation, this was a trial that was done again a few years ago that took patients who had either triple negative breast cancer or hormone receptor positive HER2 negative breast cancer. These patients were defined as being high risk, either clinically or by having a residual disease if they had received neoadjuvant therapy. And these folks were randomized 1-to-1 after completing their local regional therapy to getting olaparib, which is a PARP inhibitor, for 1 year, or placebo for 1 year. And the primary outcome here was looking at invasive disease-free survival. The majority of these patients that were included in this trial had triple negative breast cancer, so about 81%. And many of them had a BRCA1 mutation, about 70%, and the rest were BRCA2. Many patients were premenopausal as well. In terms of the chemotherapy that they received in the adjuvant or neoadjuvant setting, these were appropriately treated patients. So many folks received anthracyclines, taxanes, and some also received platinums. Here is one of the follow-up data that's showing the overall survival benefit with adding olaparib to patients who have a germline BRCA1 or 2 mutation. And we can see that adding this does improve survival. It's about a 3.4% at 4 years. We do have longer follow-up from this as well that continues to show this benefit. This does also come, of course, at more toxicity. So more GI issues, more cytopenias primarily, but these seem to be well managed. Importantly, they didn't really see an increased risk of MDS or AML compared to placebo. PARP inhibitors in general have been associated with causing MDS or AML, but that seems to be a really low prevalence. So summarizing all that, I think in the early stage space, we've made quite a lot of progress in terms of improving outcomes for patients. We've been able to add immunotherapy to improve complete pathologic response rates. And then in the adjuvant setting for folks who have residual disease, we've been able to really use targeted therapies, chemotherapy, and immune therapy to really tailor our treatment strategies and try to improve outcome and improve survival for those folks. I think we still have more work to do. Certainly adding in all these agents does come with more side effects. And so thinking about how we really creatively use either dosing strategies or treatment schedules to really make sure that we are trying to minimize toxicity, but also make these treatments more accessible in the global setting. And then really thinking a little bit more about where are areas where we can escalate treatments for the patients who need them, and where are areas where what we're doing is way too much and we can find ways to try to de-escalate in those patient populations. And then moving on to the metastatic setting. So this is a figure really that shows survival trends over time in patients who have metastatic breast cancer in general. The one I want to highlight is really all the way here to the right, which is showing triple negative breast cancer. You can see compared to other subtypes of breast cancer where we have made quite a lot of progress in terms of improving survival, we unfortunately have not been able to do that to the same extent for patients with triple negative breast cancer. We have had many approvals as listed at the bottom here in terms of what we can utilize in order to improve outcomes. But even with those, unfortunately, improvements have been pretty modest. The other thing I want to highlight here is that if you look at multiple different real-world databases or outcomes from large epi studies across the world, we're seeing that about 25 to 30% of patients that are diagnosed with metastatic triple negative breast cancer actually do not survive beyond the 6-month period. And so there's really a need to think about how do we bring up the more active or effective treatments into the earlier line setting so that these patients are able to access the most effective treatment and be able to have the best shot at trying to control their disease for a little bit longer. So this is really the general treatment strategy or algorithm I think about using for patients with metastatic triple negative breast cancer. Unlike the early stage setting, this is really dependent on whether patient's tumor expresses PD-L1 or not. If they express PD-L1, we know that adding immunotherapy like pembrolizumab has been shown to improve outcomes, but that outcome was not seen in folks who have PD-L1 negative disease. And so for those folks, we're really thinking about chemotherapy, targeted therapies. And then in the second line setting, we have options like antibody drug conjugates that are now starting to change really the outcomes of folks with metastatic triple negative breast cancer. Oftentimes, unfortunately, patients are not making it to third or more line settings. But in that space, that's really where I start to think about, are there biomarker directed therapies that we can utilize? Are there certain targetable mutations that we can select treatments for? Those folks tend to be really small, but if we are able to identify them, they can potentially respond for longer periods of time. This is the Keynote 355 study, one of the practice-changing studies in the management of metastatic triple-negative breast cancer. In this study, they combined chemotherapy with immunotherapy for folks who have metastatic triple-negative breast cancer, and they looked at outcomes based on essentially PD-L1 scores, and here they used the CPS score, and found that the benefit was really greatest in those who had a CPS score of more than 10. So that's who it's approved for here in the US. And you can see that the outcomes seem to be better and the survival is better with adding immunotherapy to chemotherapy compared to chemotherapy alone. But you do see that when we're looking at the median overall survival, unfortunately, it's not extremely long. We're still really thinking about less than 2 years for these patients. So certainly more work to do in this space. Antibody drug conjugates are other types of treatments that are now approved in the second or more line setting for patients with metastatic triple negative breast cancer. Antibody drug conjugates, very briefly, are treatments that have antibodies, in this case, sacituzumab govitecan, for example, or Trodelvy, is a TROP2 directed antibody, which is very commonly found among breast cancers, but also other subtypes of solid tumors. Yeah, and this is basically linked to a chemotherapy. In this case, it's SN38, which is a topo-1 isomerase inhibitor. And the idea here is really that we're particularly delivering chemotherapy to the cells that express this antigen, in this case, TROP2. There are other antibody drug conjugates that have been used in triple negative breast cancer as well that seem to be really promising. Here, I'm just showing you two others, Dato-DXd as well as sac-TMT, which recently have had data presented for first-line treatment of metastatic triple negative breast cancer and seem to also be really effective in that setting as well. Currently, sacituzumab govitecan in the US is approved for second or more line setting, but there are trials that have also looked at that, moving that up into the first line setting as well. Here's some older data that really shows how each of these antibody drug conjugates fare in the second plus line setting for patients with metastatic triple negative breast cancer. And essentially what you're seeing is that using the antibody drug conjugates, whether it's sacituzumab govitecan or sac-TMT or Dato-DXd, all seems to be improving the median progression-free survival compared to chemotherapy alone in these patients. And so certainly seems to be a much more effective treatment strategy for these patients. And this is the most recent data that we have. This was presented about 2 weeks ago at ESMO. In ASCENT-3, they utilized sacituzumab govitecan, and then in TROPION-02, they utilized Dato-DXd. And in both of these studies, these were being used in the first line setting, so patients had not received prior lines of therapy for their metastatic triple negative breast cancer. And in both of these cases, we are seeing that utilizing these antibody drug conjugates in the earlier phase setting compared to standard chemotherapy seems to be beneficial and seems to improve the progression-free survival in both of these cases. And so in the metastatic setting, sorry, that should say metastatic, not early stage, but we have certainly made progress, but the progress has been fairly modest. I think there is a lot of hope with some of the more novel agents and antibody drug conjugates that are coming down the pipeline that we'll hopefully be able to continue to improve on this over time and allow patients to have longer periods of time with disease control. Currently, it's not approved yet, but I do think that antibody drug conjugates will likely end up moving to the first line setting for patients. Unlike early stage breast cancer, if we are going to use immunotherapy, PD-L1 is important in order to manage disease. And then the other thing here is genomic testing that's going to be really important to allow for identification of targetable mutations, either in the germline setting or in the somatic setting. With that, I will end. Thank you so much.
You can't hear all the applause, Dame, but it's there. Thank you. Great presentation. I wonder if in the chat if people could comment whether or not they have Pembro available for their patients, and then just respond yes or no, and your country. I'd be curious to see how many people have that available. Well, now we're going to go, before we take any other questions, we're going to go on to our second presentation. Dr. Doug Yee, for those of you who might be from Ethiopia or from Mongolia, you've probably seen Dr. Yee on our multidisciplinary tumor boards over the last multiple years. Doug is my partner. He is the past director of the Masonic Cancer Center at the University of Minnesota. He is a professor in the Department of Surgery and Pharmacology. He has an extensive research background in the growth regulation of breast cancer by insulin and insulin-like growth factors. He's also had a leadership role and has been very involved with the multidisciplinary I-SPY clinical trial, which is designed to investigate new therapies and the neoadjuvant treatment for breast cancer. He has over 250 publications, and he's been a very big advocate for breast cancer patients in the United States and worldwide. So I'd like to introduce Dr. Doug Yee, who will be speaking about HER2 positive breast cancer. Thank you, Doug.
Thank you, Todd. That's a very kind introduction. I'm going to talk about HER2 positive breast cancer. This is the outline. I thought I'd spend a minute at the discovery of HER2 in breast cancer and then talk about measurement and then finally get to therapies. The reason I wanted to spend a minute about discovery of HER2 is because I do think it is one of the translational triumphs in all of science, but particularly in breast cancer. This was an editorial written, sort of a concept paper written by my former boss, the late Bill McGuire, and Gary Clark, who talked about prognostic factors in treatment of breast cancer. And the statement here was, why not simply treat all patients with node-negative breast cancer with systemic therapy? And the answer that they provided is one should not. First, about 70% of such patients are cured without any adjuvant therapy. And having known Bill, he was driven to try to understand who were the 30% who did very poorly. So this was published in 1992, and he knew part of the answer already. Part of the answer was amplification of the HER2 new oncogene. This was a study he did in combination with Dennis Slayman. This is the actual primary data of the paper in Science, which was an old-fashioned Southern blot, which probably nobody has really done for years. But these are patients' tumors with DNA extracted, run on a gel, and looked at how many copies of HER2 there were. If there was any amplification, and they looked at disease-free survival and overall survival, not a lot, but if you had more than 5 copies, it showed that they had a much worse prognosis overall. So to me, that was sort of the hallmark of where this field started. If this was a prognostic factor and it was there in the tumor, then it could be targeted. We have stopped doing southern blot. Actually, we have never done southern blots in the clinical setting, but this is a demonstration of the immunohistochemical measurements. It can go from 0, 1+, 2+, and 3+. I don't know if there are any pathologists in the audience, but it took a long time to actually figure out how to standardize and measure HER2 and what to do about these cases that were 2+. The second thing we could do is fluorescent in situ hybridization. This demonstrates staining for the centromere of the chromosome 17 where HER2 is, and the orange dots are actually HER2 itself. So if you're an fish person, you can see, well, this cell has maybe 2 centromeres and I don't know, 10, 20 copies of HER2, so it was clearly amplified. These are the ASCO-CAP guidelines for HER2 measurements, and this was published in 2018. And I mentioned to you that the discovery was in the late 90s. So it took a good 20 years to actually figure out, or sorry, in the early 90s. So it took almost 30 years to figure out how to do this that is clinically actionable. And I'm not going to go over this in gory detail. I just want to point out some key things. It has to be a validated immunohistochemical assay. There have to be controls and on-slide controls showing staining. So you got to show it works. And then if they're 3+, they're clearly positive. If they're 1 or 2+, they're not, 0. And if they're 2+, they're equivocal. And you should refer this then to fluorescent in situ hybridization. I think this is the pathway most labs perform in the United States, but I would just say it's very critical to try to understand, does your patient have a HER2 amplified tumor? So why do we care? It's because there are targeted therapies to HER2, and we'll talk about this a little bit, but I do want to comment that HER2 stands for human epidermal growth factor receptor 2, which implies there are more, and it also implies as a growth factor receptor, it has an extracellular domain and an intracellular domain. So this is a cartoon of trastuzumab, which was created at the time by Genentech. I will say they first created this antibody because they wanted to have a reagent to do immunohistochemistry staining of tissues. Nobody was going to do southern blots, but preclinical studies showed that when the antibody was given to cells that overexpress HER2, it was inhibitory. So the antibody, because it was a mouse monoclonal, had to be humanized. The little yellow areas here are meant to be the remaining domains of the variable fragment that are mouse, and the rest was engineered to be human antibodies, so you wouldn't develop human anti-mouse antibodies if a mouse antibody is given to a human. And was first tested in metastatic disease. So again, I just want to pay attention to the dates. 2001 is when this paper was published, and if you will accept roughly 1990 is the date when HER2 was first discovered, you can say, well, that's a long time or not that long a time, but that's how long it took to make this a drug. So this is a clinical trial that used chemotherapy with a monoclonal antibody against HER2 for metastatic breast cancer that overexpressed HER2. And I just want to, as a sidebar, say the measurement of HER2 was not so clear in that setting, but these are the results they had. In other words, they didn't have the standards as I outlined for ASCO-CAP. But these were the results. If patients got chemotherapy plus trastuzumab, the progression-free survival was superior to chemotherapy alone. And this trial then really did end up making the standard of care this addition of chemotherapy to trastuzumab. Now, the one thing that we also understood at this trial that was not understood prior to this trial being performed, everybody thought that trastuzumab would be fairly safe and not toxic because it was not expressed in normal human tumors. As it turns out, it is expressed in patients that have some damage to their heart. So I just want to show you, back then we did this with AC, either epirubicin or doxorubicin, cyclophosphamide, and trastuzumab, reported a percent heart failure rate of about 16%, compared to the chemotherapy alone was 3%. Even with paclitaxel and trastuzumab, there was a heart failure rate of 2% and 1% with paclitaxel alone. So depending how you look at that, that was either double the rate, but certainly heart failure that was I'm sorry, I'm presenting this wrong. It's 27, these are the actual numbers, 27% versus 8%, 13% versus 1%, and the numbers in parentheses are what was called severe events. So we have to pay attention to cardiac toxicity, and we have learned that damaged heart expresses the HER2 protein, and that's probably the reason you see this toxicity. So, of course, when things work in the metastatic setting, they are applied to the adjuvant setting. This is a paper that reviewed the meta-analysis of roughly 9,000 patients who are in various different clinical trials. It showed the hazard ratio of favoring control, or excuse me, the odds ratio of favoring control, which is chemotherapy alone, or favoring trastuzumab, which is chemotherapy with trastuzumab. And it showed for every study, and I know you've all seen these forest plots before, but the size of the symbol means how big the study is. The bars represent the confidence intervals, and all of the studies that were sufficiently sized demonstrated that addition of trastuzumab, the adjuvant chemotherapy, reduced the odds ratio of recurrence in patients with HER2 positive tumors. So again, that became standard of care. This is a good, I like this cartoon because it tells you when and where and for what drugs were developed. So this is trastuzumab, as we talked about. It first appeared in 1998. The little different colors represent the countries where it's approved. The letter represents the disease state. So approved for metastatic disease is 98. It took a long time to have approval in the adjuvant setting. We're going to say a few more words about pertuzumab, which is a second HER2 antibody. M is metastatic, N in this case is neoadjuvant, A in this case is adjuvant. I'm not going to say too much about the tyrosine kinase inhibitors, but as I mentioned, this is a growth factor receptor. HER2 has an intracellular tyrosine kinase domain, and a variety of tyrosine kinase domains have been approved. Dr. Idossa has already introduced the concept of antibody-drug conjugates, and we'll spend a little more time talking about antibody-drug conjugates. But at any rate, I think this is a great timeline and an incredible triumph of science providing new therapies for our patients based on a molecular driver associated with poor prognosis. And I started this discussion saying, well, this was a poor prognosis, but I think most of us oncologists would rather have a HER2 positive tumor these days than a triple negative for sure. And I personally would rather have a HER2 positive ER negative than ER positive tumor, just because these tumors respond very well to the anti-HER2 targeted therapies. So I kind of alluded to this already, but how do the therapies work? HER1 is also known as EGF receptor, which we know about, and this was the initial observation. Trastuzumab would bind HER2 and potentially interfere with its signaling pathways. The second antibody that was created was pertuzumab, which also binds HER2, but pertuzumab's ability to interrupt HER2 interacting with other family members, HER1 or HER3, is its major biological difference between trastuzumab. And I will say a few more words about the antibody-drug conjugate. But the principle here, at least in this cartoon, is you end up blocking the signaling from the HER2 pathway. And I know we don't have a full time to talk about this. It's not entirely clear that's the only mechanism, but that's the mechanism we use to explain this particular drug and its action. So it was interesting to me, I think, that you could give two drugs to the same target, two monoclonal antibodies to the same target, and have benefit. So this is the Cleopatra study in metastatic disease, which used trastuzumab plus the taxane docetaxel plus pertuzumab, or just trastuzumab and docetaxel with a placebo. And the primary endpoint was progression-free survival, as is with most metastatic trials. This showed that the demonstration of two antibodies versus one antibody was an improvement median overall survival was 41 months compared to the 57 months, again, demonstrating that blocking HER2 in more than one way was a benefit. And that became an interesting observation in the standard of care in some settings. So, as I mentioned, once things are approved in the metastatic setting, they find their way up into the earlier phase study. And I just want to say a word about the neoadjuvant versus the adjuvant therapy. So, as you all know, neoadjuvant therapy allows for more breast conservation surgery. There is no difference in the outcomes, either in event-free or overall survival between neoadjuvant versus adjuvant therapy. However, the response to neoadjuvant therapy can be observed and carries prognostic information. Dr. Idossa introduced this concept earlier with the idea that pathologic complete response identifies patients who will have favorable outcomes in the long term. So this is kind of a busy slide, but I wanted to show you the results of one of the early trials of trastuzumab, pertuzumab, and chemotherapy called NeoSphere. This is trastuzumab plus docetaxel. This is the 2 antibodies in docetaxel. This is the 2 antibodies without any chemotherapy. And this is pertuzumab versus docetaxel. So first, if we go with the endpoint of pathologic complete response, I'm not going to go over every single one of these lines, but the combination of chemotherapy, pertuzumab, trastuzumab yielded the highest pathologic complete response rate. Pertuzumab by itself, which I think was a surprise to Genentech, was not all that effective. In fact, it performed more poorly than trastuzumab alone. And I do want to point out that 18% of patients who only got the antibodies had a pathologic complete response, which is something we don't completely understand, but it's worth noting. Because this was the highest response rate, the standard of care became using all of the antibodies that we have and chemotherapy. So if I show you why we believe PCR, and you've seen similar results from Dr. Idossa, in red, if you have a pathologic complete response versus not, you do better. And if you break it up by hormone receptor status, hormone receptor negative is shown in the reddish and blue. Red and blue had the biggest separation, but still also relevant to have a pass CR for the patients who had hormone receptor positive and HER2 positive disease. Now, I do, and Dr. Idossa mentioned this already, the concept that it's just not binary. You don't just get complete response or residual disease. There's a staging system, the residual cancer burden calculator popularized by Fraser Simmons and MD Anderson. It's available online, and it will then grade you with a continuous index in RCB classes 1, 2, and 3, and it shows you classes 0, pathologic complete response, 1, 2, and 3 all convey prognostic information. The calculator is composed of how big the tumor is, how much cellularity is. I just did an example of a 5 by 3 centimeter tumor that was only 5% cellular. That comes out to be a residual cancer burden of 1.566. And if you notice on the index, it's just on this side of 1.566. So at any rate, grading is important, and it's a thing that I think in the U.S. Almost all pathologists will grade this in patients getting neoadjuvant therapy. So I borrowed this slide from Dr. Idossa down here, where this is an actual sort of way to think about how you do this with HER2. If you have an operable stage 2, less than 2 centimeters, node negative or microscopic disease, I didn't go over the results of the APT trial. It's referenced here. Dr. Talani has done a lot to try to de-escalate therapy, but you probably can just use trastuzumab and paclitaxel. In contrast, if you have a big tumor, think hard about neoadjuvant therapy if you have the drugs available. I think the idea that a taxane and the 2 antibodies, or taxane carboplatin and 2 antibodies is worthwhile. I do not think, and I think this is true, most studies now suggesting anthracyclines have very little to add. Go to surgery. If they have a pathologic complete response, that's fantastic. You probably should complete the year of HER2 targeted therapy. if they don't have pathologic complete response, then there are other therapies, particularly antibody drug conjugates, as well as a tyrosine kinase inhibitor, neratinib. So I want to go back to this and just say a word about the antibody drug conjugates. Dr. Idossa has done a fantastic job of introducing them. The first drug that was approved was the antibody drug conjugate we call TDM1. Trade name is Kadcyla. It has trastuzumab. It has a non-cleavable linker. It has the payload of amitansine, the DM1 part, which is an antitubulin. It has 3.5 drugs per antibody. The second drug approved, I'm using its old name before it got the name trastuzumab deruxtecan, was commercialized. It has a different payload, the topoisomerase inhibitor. It has a cleavable linker, and it has 8 drugs per antibody. These drugs, and this slide is a little bit old, have potent bystander killing effects thought to be due to the cleavable linker, while this did not, thought to be due to the non-cleavable linker. The only point I want to make about these 3 drugs are they're all the same antibody. They're all trastuzumab based. This drug, SID985, is not going to make it, I don't think, even though the phase 3 was positive. I think the company decided not to move it forward. But they're all different drugs, even though they're based all on the same antibody. So I want to end with this. HER2 in breast cancer, I would argue discovery of HER2 was an important landmark in breast cancer therapy and provided a new target for treatment. There are multiple drugs approved in the US, including the antibodies we talked about, the tyrosine kinase inhibitors, and the antibody drug conjugates we mentioned. As I said, discovery of HER2 has turned a poor prognosis tumor into a better prognosis tumor. And again, trials demonstrate superiority of anti-HER2 therapy compared to chemo alone in all the settings that's ever been looked at, neoadjuvant, adjuvant, and metastatic settings. So I think that the availability of at least trastuzumab should be something that we can advocate for our patients. And as Todd has said, it's not clear that everybody has the availability, but it's, I think, an important advance in breast cancer therapy. So thanks, I'll stop there.
Great. Thank you very much, Doug. I learned a lot, particularly like the development of HER2 therapy and how that all came about. I've learned a lot also from the chats today, and for our speakers and panelists, it's interesting to see that most countries that are represented here today do not have access to Pembro or pertuzumab, or if they do, it's very, very expensive. I don't see any questions right now from everyone, from the attendees, but maybe I'll start with Dr. Idossa, since we don't really, I was really intrigued by the Planet study. And since we don't, a lot of places don't have the availability of Pembro in usual setting, is there do you know if there's a cost benefit with a low dose, and how much, how much less is that going to be compared to traditional Keynote 522 immunotherapy?
So they used the 6-week schedule, so 50 milligrams compared to 400 is what standard is. So that would be essentially like 8 times less, right? So presumably you could take one person's dose and give it to 8 people. I don't know. I don't think they've done how much less that would cost for the 50 milligrams compared to, I don't know that it's going to be 8 times less, probably not. But I think it was also really intriguing. If you can get essentially the same amount of benefit, both 13% increase in PCR, I think it certainly raises the point of, should we be potentially considering really creative trials like this so that we can allow for more access in middle income or low income countries where they're not going to be able to get access to the standard doses. Hopefully they will publish on that. I didn't see a publication. It was just the abstract.
Okay. Very good. Thank you very much. Is there a way, I still don't see any other questions, shy group. Doug, is there any other way to sort of to save costs that you know of with to get HER2 and Pembro, shorter courses, lower dose? Is that a possibility, do you think?
So I think, and I didn't go over this literature, it is the concurrent administration of trastuzumab and chemotherapy is critical. Some of the early stages used it sequentially, and the outcomes were better if they were concurrent. The issue about how you had to really give it for a year is still being discussed. Some of the trials that have done shorter trials, I hope you can distribute this slide so people can look, but the one little trial called FinHER tried to do it for like 9 weeks and shorter, and they showed sort of inferior outcomes. So I think the ability to shortcut, let me rephrase that. If you only had a limited supply, I would certainly give it with the chemotherapy.
Okay.
And whether you need the additional, if you give chemotherapy 12-ish weeks or so, if you need the additional 40 weeks, I'd say you can maybe go halfway and try to give 6 months, but it's not clear that you can eliminate that portion of the regimen.
Thank you. We have a question from Dr. Malik from Kenya, and either one of you can take this. How do you assess for cardiotoxicity, ejection fraction, myocarditis, etc.?
Go ahead, Dami.
So for triple negative breast cancer with Pembro, fortunately, the myocarditis rates are really low. So usually on the order of 1 to 2%, but obviously if it happens, it can be associated with quite high morbidity and mortality. So I think early recognition is pretty key. If folks are complaining of any kind of chest pain or any cardiac symptoms, getting a troponin, getting an echocardiogram to really evaluate, and getting cardiology involved is pretty important. Technically, the way to diagnose that is getting an MRI, a cardiac MRI with or without a biopsy, which I think can be extremely challenging to do. Unfortunately, there's not any non-invasive ways of regularly monitoring for myocarditis related to immunotherapy, as far as I know. Obviously, much more straightforward, Doug, for monitoring and surveilling for HER2 positive breast cancer.
Yeah, certainly, just in terms of the number of things that can go wrong with the antibody therapy, I'd say they're much higher on the list of pembrolizumab than they are for trastuzumab. You can have inflammation of pretty much any organ that you choose. So I would also argue that it's just, if you're using pembrolizumab, it's just not the cardiac effects. I think the endocrine effects are pretty important, and skin and gut and you name it, you can see it. So for the trastuzumab, pertuzumab toxicity, it's primarily cardiac, and we here get standard of care kind of baseline cardiac echo, and then get one roughly every 3 months while patients are on therapy. The good part about trastuzumab-induced cardiac cardiomyopathy and decreased ejection fraction is it's pretty reasonably treatable in terms of stopping drug and giving sort of afterload reduction cardiac meds, and most patients recover from that. So at any rate, that's the standard of care. We even have it built into our order set. Our nurses will yell at us if we haven't gotten an echo in 3 months, and we pay pretty close attention to that. So hopefully cardiac echo is available for everybody or for most everybody, and that's a good way to monitor.
Thank you, both of you. One last question from Dr. Songwei. Any comments on low HER2 breast cancer? What's your experience with these patients?
Can you say that again, for HER2 low?
Yeah.
So for HER2 low disease, it's technically defined as folks who have HER2 1+ or 2+ by immunohistochemistry, but the FISH testing is negative, so that's defined as HER2 low disease. In the triple negative setting, I'm very commonly using drugs like Enhertu, which is initially approved for the HER2 positive setting, in order to give them more options for treatments. So I think we're starting to learn that even defining what really, I think HER2 is making us rethink how we define HER2 positive disease, because it seems to be more kind of on a spectrum. And even folks who really express small amounts of HER2 positivity, like HER2 ultra low, seem to be benefiting from treatments like HER2. So I think we need better ways of really defining who those patients are so we can get them drugs like HER2. I think that with the development of more antibody drug conjugates, that's probably going to be a more important question to keep considering.
Well, thank you, Dami. I want to thank both of our speakers today. I know it's a lot of work to prepare these slides, and I really appreciate your expertise here. I'm sure our attendees do as well. So thank you very much. Our next seminar is going to be on December 2nd. We're going to be talking about quality of life and physical therapy for patients with breast cancer. I think this is going to be a very important topic. I think we're going to skip January due to the holidays here and then resume again in February. But the next presentation will be, the next seminar will be December 2nd. So thank you all for participating, and special shout out to our speakers today. Have a good morning, afternoon, and evening, guys.